The broadcast is now starting. All attendees are in listen-only mode.
Good morning, good evening, good afternoon, wherever you are in the world, and thank you for joining us for today's webinar. My name is Evelyn Holmes, and I am the Education Coordinator here in ISQua. I am delighted to be looking after this webinar for you today, which is Ambulatory Quality Measurement in the USA Post-Health Reform with Dr. David Nash. Dr. David Nash was named the founding dean of the Jefferson College of Population Health in 2008. This appointment caps a 25-year tenure on the faculty of Thomas Jefferson University. Dr. Nash is the Dr. Raymond C. and Norris N. Grandin Professor of Health Policy, a board-certified internist, and a principal faculty member for Quality of Care Programming for the American Association of Physician Leaders in Tampa, Florida. Dr. Nash serves on the NQF Task Force on Improving Population Health and the John M. Eisenberg Award Committee for the Joint Commission, and is a founding member of the AAMC IQ Steering Committee. He has been repeatedly named to the Modern Healthcare's list of most powerful persons in healthcare and has governance responsibilities for organizations in the public and private sectors. Currently, Dr. Nash serves on a number of boards, including Mainline Health Philadelphia, Pennsylvania, where he also chairs the Board Committee on Quality and Safety. Humana Incorporated, a not-for-profit publicly traded healthcare company. Vestigen Technical Textiles in Orlando, Florida, and InfoMC in suburban Philadelphia, and the Healthcare Advisory Board for Arsenal Capital Partners in New York City. Dr. Nash has received many awards in recognition of his achievements, including the Top Recognition Award from the Academy of Managed Care Pharmacy, the Philadelphia Business Journal Health Heroes Award, and was named an Honorary Distinguished Fellow of the American College of Physician Executives in 1998. Dr. Nash also received the Elliott Stone Award for Leadership in Public Accountability for Health Data from NAHDO, the Wharton Healthcare Alumni Achievement Award, and the Joseph Wharton Social Impact Award from Wharton, and along with JCPH, the Philadelphia Business Journal Award for Innovation in Medical Education. Dr. Nash's work is well known through his many publications and public appearances. He has authored more than 100 peer-reviewed articles and edited 23 books. He is an editor-in-chief of American Journal of Medical Quality, Population Health Management, P&T, and American Health and Drugs Benefits. Dr. Nash achieved a BA in Economics Phi Beta Kappa from Vassar College, his MD from the University of Rochester School of Medicine and Dentistry, and an MBA in Health Administration from the Wharton School at the University of Pennsylvania. The duration of this webinar will be approximately 40 minutes, after which there will be 15 minutes for questions. Please type your questions into the question box, remembering to include where you are from. Enjoy the presentation, and over to you, Dr. Nash.
Well, thank you so much for that wonderful introduction. Good morning, good afternoon, good evening. It's just about 8 o'clock in the morning Eastern Time in the United States, and we're coming to you from Philadelphia, Pennsylvania. I'm 4 blocks from the Liberty Bell and Constitution Hall, and of course Philadelphia is the founding city of our country. Also, Philadelphia is the home of 5 medical universities, including Thomas Jefferson University, where we are broadcasting from. So thank you so much for carving time out of your busy day to join us. My intention is to have some fun, give you an update, and have a conversation at the end of our time together. Next slide, please. So, next slide. Great. So Jefferson, Thomas Jefferson University is a health sciences university in downtown Philadelphia. We don't, at the moment, have any undergraduates, business school or a law school. We're exclusively focused on healthcare. And we have 6 colleges in medicine, pharmacy, nursing, allied health, graduate science, and the 6th and smallest college, and the newest, only 8 years of age, is our College of Population Health. And I have the privilege of being the founding dean of this college. And I have absolutely fantastic faculty and staff and researchers who helped me. This is a photograph of the floor of our gymnasium, where at the moment we don't even really have a basketball team, so this is just for intramural fun. Next slide. So my intent today is really to break our time together into three discrete parts. First, a little bit of history about the overall quality movement in the United States, with a special emphasis on academic medical centers like Jefferson. Just as an aside, our country has just about 160 now academic medical centers, which include a large university, hospital, a medical college, and affiliated colleges like ours. So part one, you can't know where you're going till you know where you have been, so we'll do a little bit of history. Part two, I'd like to focus on the emergence of ambulatory measures for quality and safety, especially as they relate to the passage of the Affordable Care Act. More on that in part two. And then in part three, the concluding part, I'd like to give you my sense of some of the key challenges we're going to face in the measurement arena in the very near future. Next slide. Well, today is not the appropriate time for a treatise on the Affordable Care Act, but this month, March, represents the 6th anniversary of the passage of the Affordable Care Act, and I couldn't resist putting the slide up. After all, this is the cover of the British news magazine, The Economist, and that was the cover. We did not doctor this online. So the question here with President Obama dressed, is he either a surgeon, is he a pain doctor, an anesthesiologist? I can't really tell. But one thing is for sure, colleagues, that is a big syringe that he is holding, and it is going to hurt, and we'll be discussing aspects of some of the measurement pain that we're going to feel together. Next slide. I call this the full Monty slide, and I want to give attribution to some of my colleagues at the University of Massachusetts who helped me with this. And again, I just wanted to give you an overview. We're not going to do a detailed treatise on two critical books, the 1999 book, To Err is Human from the Institute of Medicine, followed on by the 2001 book, Crossing the Quality Chasm. I would hope many of our listeners are familiar with these vital texts of the last 16, 17 years. Below that is a quick picture of the Dartmouth Atlas, which once again demonstrates inexplicable variation we do with regard to outcomes, utilization, and cost in our country. There's the famous Elizabeth McGlynn results from her classic New England Journal of Medicine piece now more than 13 years ago, that based on chart review in hundreds of hospitals and thousands of cases, from a retrospective perspective, we get it right about 55% of the time. And I'm confident that many of our listeners are very familiar with aspects of this, but this gives you some sense of, in the last 15 years, there's been incredible attention to the issues around trying to sort out unexplained clinical variation in resources, unexplained differences in outcomes that can't be explained based on patient characteristics, and of course in our country, incredible spending on healthcare, which we'll return to in a moment. Next slide. I trace the movement that we are all a part of, at least in the United States. I trace this movement to the First World War, and this is a citation that I think rings true today just as it did nearly 100 years ago. So you could read along with me. Let's just say, all integrated delivery systems are accountable to the public for their degree of success, and if this initiative isn't taken by the medical profession, it will be taken by the lay public. Well, we could have substituted here, of course, March 23, 2016, but I think some of our listeners would be surprised to learn that in research for one of our books, we discovered this is an exact citation from the inaugural meeting of the American College of Surgeons during the First World War. And we're going to come back to the theme here of public accountability and transparency, and just how important that is when we get to the third and final part of our time together. So tuck this away. Historical reference, very important, while at the same time, accountability and transparency, a theme we will return to in a little while. Next slide. Again, with regard to the history of our movement, no webinar would be complete without a moment of recognition for the great-grandfather of quality in our country, the one and only Dr. Ernest Codman. Dr. Codman was a general surgeon practicing at Massachusetts General Hospital on the banks of the Charles River in Boston. He developed a system called the end result idea, which was simply a collection of file cards where he described after each surgical procedure how he could have done a better job. Very early on in the First World War era, Dr. Codman was taking notes on his own work in the hopes of one day publishing these file cards, this end result idea, in order to share his reflection on improvement and therefore raise all boats and improve surgical practice at the turn of the 20th century. Next slide, please. Well, Dr. Codman brought his idea to the members of the Massachusetts Medical Society and asked them if it would be appropriate to publish his results, his self-evaluation, his public accountability idea. He asked the members of the Mass Medical Society should he publish it, and as a result of his request, they banned him for life from membership in the Massachusetts Medical Society, and over a century ago, this was a very bad thing. He died a pauper in Cambridge, Massachusetts, and it wasn't until July of 2014, that the surgeons at Massachusetts General, led by Andy Warshaw, at the time the chief of surgery, took up a collection to buy a headstone for Dr. Codman. I know you must be shaking your head in disbelief, but Dr. Codman, the great-grandfather of our movement, laid in an unmarked grave from the time of his death in 1940 until 2014 in a small cemetery not too far from Massachusetts General Hospital. So we owe Dr. Codman a great debt of gratitude for his courage in marking down how he personally could have improved with the goal of improving everybody else's performance. Next slide. Let's fast forward to the modern era, and certainly in our country and in most Western nations, the notion that medical error is a public health emergency has emerged since publication of To Err is Human in 1999. This is a front page, second section headline from just a few years ago in the Wall Street Journal, a story by Marty Macari, our colleague at Johns Hopkins University, describing his book appropriately called Unaccountable Care. And of course, when you have a headline like this in the newspaper, this tends to get persons' attention, how to stop hospitals from killing us. Next slide. Well, in our country, we have a particular challenge in that when you look at how the United States stacks up relative to most of you who are listening and participating today, you can appreciate that the best available evidence from our Institute of Medicine, January 2013, a little over 3 years ago, says that despite spending nearly 19% of our gross domestic product on healthcare services, it puts us at number 17 in the world. So we spend the most, and we're ranked number 17. And on top of all of that, despite that spending, we can look forward to our children having a shorter lifespan and poorer health than us for the first time since the conclusion of the Second World War in 1945. So we are facing a conundrum of great importance with deep historical roots. 19% of the GDP, ranking us at number 17 in the world. From a public perspective, next slide please, this is what our typical newspaper, the Washington Post, sort of puts it very succinctly. Once again, we have the most expensive, least effective healthcare system in this global survey. Next slide. From an individual family perspective, this takes a great toll on our very large middle-class population in our country, and you can see this inexorable rise of cost. And when we talk about 19% of the GDP, that's one thing, but when you see what the average annual expense for a family of 4 is in our country in this year, nearly $28,500, continuing to rise, you can get a greater appreciation for why we had to have the Affordable Care Act and whether that's actually going to be able to reduce the trajectory of spending. Well, we'll return to that in part 3 of our time together. Okay, next slide. So I think this picture is illustrative of our current challenge. And here is the young physician trainee house officer balancing between these two canoes on this make-believe lake. And in each canoe, on your left, the historical and current fee-for-service. So this is how doctors have been paid for nearly 70 years since the Second World War. The more we do, the more we get paid. And since the passage of the Affordable Care Act, we've begun the transition, and we're 6 years on, into what you understand to be the value-based payment and a population health management system, where because of changing economic incentives, we're moving away from piecework and reimbursement based on piecework, where volume determined income. We're moving away from that to a world where we're going to be paid based in large part on our performance with a population. For persons from nations with centralized payment systems and national payment systems, this is not a new concept to many of you for sure, but it's a very new concept to us. So I would just summarize before we transition to part 2. I believe physicians in our country are facing 3 choices. They can jump in the canoe of population-based payment and sail happily off into the future, and that will require change in our culture. Or they could jump into the canoe of historical and fee-for-service, but what they don't know is 100 yards downriver is a 1,000-foot waterfall and they will perish. Or, of course, like many of my clinical colleagues at my age, they can simply jump into the lake and retire. Next slide. So let's summarize the first part of our time together. This is not new information to our listeners. We're spending in our country nearly 19–20% of the world's largest economic engine on healthcare costs. We have inexplicable variability in quality and outcomes across even individual zip codes down to the township level. We have widespread lack of use of evidence-based practice, lack of adherence to well-established guidelines and standards which have been documented for at least 15 years. And of course, we have severe problems in communication and coordination because when you're paid to do piecework, there is no economic incentive to coordinate care. Having said all of that sad news, let's then go to the next slide and start part 2 of our time together. And I'm the groundwork for the increase in interest in ambulatory measurement and payment in our country. A little bit of background. So as many of our listeners know, the federal government in our country is the single largest payer for healthcare services. So although, of course, we're not nationalized, Medicare and Medicaid make up the vast majority of healthcare spending. In 2016, an easy way to remember Medicare spending is $1.2 billion per day. If the Medicare organization known as the Centers for Medicare and Medicaid Services were to somehow secede from the Union of the United States, it would represent the world's 7th largest gross domestic product, just to put that into perspective. So the federal government is our biggest payer. Given that history, next slide, starting back in 2005, so nearly more than a decade ago, we are beginning to see that Medicare, CMS, the Center for Medicare Services, began some demonstration projects a full 5 years before health reform, seeking ways to change payment to change practice. And we called that early movement the first Pay for Performance initiative. This then evolved into, on the ambulatory side, a fascinating program called PQRS, noted here as the Physician Quality Reporting System. While we weren't paid based on the actual scores, we were incented to begin the process of cataloging and characterizing what we were doing in the office, knowing that in 2007 we were just getting the machinery ready to do this kind of reporting, that by sometime in the near future we would be paid based in part on ambulatory outcome. 2 short years later, during the height of the 2008-2009 recession, the federal government pours somewhere close to $20 billion into information technology to jumpstart the cataloging, jumpstart the implementation of what's come to be called meaningful use. So this gives you some of the history. 2005, the group practice demonstration projects to test pay for performance. 2007, PQRS. 2009, billions of dollars going into technology. Next slide. And then at the close of 2009, a very important report that laid the groundwork for the transition from pay for piecework to value-based reimbursement, just like that physician precariously balanced 2 canoes. Finally, of course, this report provided a vision for the transformation of Medicare from this fee-for-service volume-based reimbursement to more of a value-based, what we now come to call a population focus. Next slide. So in March of 2010, President Obama, in a big ceremony in the White House, signs the Affordable Care Act. Probably could not be done today given the fractured nature of our political system, but this represented a watershed event not only in our political history, but certainly in the history of healthcare in our country. With coverage expansion and with delivery system reform came financial reforms, which also brought with it the need for a new generation of measures of what we're doing, not in the hospital, but outside of the hospital in the ambulatory setting. Let me give you a quick overview of some of the key components of the Affordable Care Act so we can then make a transition deeper into part 2 to understand what these measures are and why we need them. Next slide. So the Affordable Care Act, with regard to quality and safety, rests on 5 very important pillars, and this often does not make press in our country, so I'm very happy to be bringing this to you. So health reform builds on basically an infrastructure that has 5 components. The first is a national quality improvement strategy. I have a detailed reference I could tell you about, where we do have at the federal level an interdigitation of major groups involved in promoting a national quality and safety agenda. We'll come back to that in part 3. Certainly we're here today talking about that second pillar, quality measure and development, because to promote pay for performance, you have to have measures of performance. To promote value-based payment, you have to have measures of value, and that's what we'll focus on in this section. Certainly the move to value-based purchasing, a heavy emphasis on prevention and wellness, and then the creation in our country of a series of new entities, probably best known overseas would be the Patient-Centered Outcomes Research Institute, known colloquially as PCORI. Next slide. But this is my favorite one PowerPoint description of the Affordable Care Act with regard to the underlying cost containment and payment reform. And just very quickly, let me hit the highlights. So since 2010, we've been driving to a world characterized by these 4 boxes. So let's go clockwise. So box 1, tying payment to evidence and outcome. Well, this is the cornerstone of value-based payment. Instead of being paid just to do a service, we're going to link that payment to the outcome, and we'll come back to that in a moment. Bundling payment for physician and hospital services, you might refer to that as a global payment, sometimes also called capitation payment, but we're moving to a world where we're going to link the payment and cover all the costs, leaving critical clinical decision-making up to physicians, but also putting the burden on us to make sure we're using the appropriate evidence and following a guideline. Accountability for results, this goes back to 1918, and now we have all kinds of new structures, patient-centered medical homes, accountable care organizations, and a series of other structures, all since the passage of the Affordable Care Act in 2010. Finally, Medicare has also only recently, in the last 2 years, begun to actually reimburse physicians for care coordination, and most recently, reimbursing physicians to have a discussion with families about care at the end of life. Next slide. So this diagram, I think, is a good summary, and on the x-axis is the care continuum, and on the y-axis is the degree of shared economic risk. And I think it's self-evident that the cornerstone, the early strategy is pay for performance, and therefore we need new performance measures. And then we're going to have one payment for a hospital and physician cost, so we need to have a very good idea about those care transitions in and out of the hospital. And then all the way to a shared savings model, which would include nurse rehabilitation centers, ambulatory care sites, and the office itself. So as the care continuum matures on the x-axis, moving to the right, the degree of shared risk increases, and it brings with it the need for a new generation of ambulatory measures. Next slide. This is a quick overview of some of the current inpatient measures. And we're not going to focus too much on these, but it gives you a sense of how far we've come in the last 5 or 6 years, where doctors and hospitals can be have monies withheld if they don't achieve certain quality scores, if they don't reduce admission, if they can't drive down hospital-acquired conditions. So this is the inpatient picture. An ambulatory picture is evolving, and that is really the focus of the third part of our time together. So let's go to the next slide and begin part 3 to give you some sense of where we're headed. So within the Affordable Care Act is something that has come to be known globally as the triple aim. And the triple aim articulated in this PowerPoint is to accomplish 3 things. To deliver better care, care of higher value, to focus on keeping patients healthy, and to spend money in a smarter way, getting a better outcome for the monies that we are spending. And this wheel going around 1 through 6, I'm not going to read all of this, but I think this is very important because this is the actual official Center for Medicare Services 6 top priorities as we move forward deeper into health reform. And let's just pick 1 or 2 of these. Promoting effective communication and coordination, critically important, and then promote effective prevention and treatment of chronic disease. So really, in the modern era, in the last 6 years especially, we're seeing explicit recognition of moving the world's largest payer for medical care services towards communication, coordination, prevention, and treatment of chronic disease, and away from the high technology, extra focus on what goes on within the 4 walls of an academic medical center. Next slide. This then brought with it the evolution of ambulatory quality reporting. And we're in the very nascent stages of this evolution, probably less than 3 years on. PQRS, as we noted back in 2007, laid the groundwork. Today we have something we call GPRO, or the group practice reporting, where group practices like our faculty at our medical college need to report on 17 office-based, largely primary care quality measures, and then moving on to the accountable care organization, where we have currently more than 33 metrics that determine our level of reimbursement. These metrics are focused on, not surprising based on our topic today, things like care coordination, prevention, and patient safety. Colleagues, you appreciate that the office is a dangerous place, and research in our country points out that the number of errors in the ambulatory setting exceeds the number of errors by nearly a factor of 4 in the inpatient setting. The good news, however, is, of course, most errors in the ambulatory setting do not cause patient harm. Next slide. As this evolution of ambulatory reporting continues, this gives you a glimpse into the future. And I can summarize this by saying in 2 short years, 2018, Medicare expects that 50 cents of every dollar, half of every dollar spent on Medicare, will be connected to an outcome measure, including measures in the office setting. So we are in the midst of not just an evolution, but a revolution of trying to create appropriate measures for what we do in the office. Many of you are familiar with these largely process-based measures. Did we order the cholesterol? Did we send the diabetic patient for the retinal annual eye exam? Did we check the urine for protein? Did we get pulmonary function tests on the severe chronic obstructive pulmonary patient? These are largely check-the-box process measures, and we're moving pretty quickly in the ambulatory setting towards some more outcome-based measures, like preventing readmission, like patients' functional status, like patients' level of satisfaction and understanding about their medication. Next slide. In our country, as part of this ambulatory movement, there are certain leading institutions like the Northwell System, North Shore Long Island Jewish in New York State, not far from where we're sitting, where every doctor's ambulatory scores have been put on the internet for all patients and other customers to see. So, colleagues, I want you to take a deep breath for a moment and just think about this strategy. All your patient satisfaction scores publicly available for inspection by everybody 24/7 worldwide. Well, I don't know about you, but that makes me a little bit nervous. But I'm an old guy. I'm sure many of our younger clinicians, they will grow up in an arena where this type of ambulatory measure, patient satisfaction, is a publicly available measure, just like Dr. Codman was thinking about nearly a century ago, public accountability and transparency. Next slide. Currently, you can go to medicare.gov anywhere across the planet where there's internet access, and you can get aspects of some of these currently available ambulatory quality measures on a physician-specific basis. So look where we have come in 6 years since the passage of the Affordable Care Act. What I'm showing you here, medicare.gov, is very new and is all part of the move toward transparency and accountability to drive us to a value-based reimbursement system. We could quibble for sure about the quality of the data, its completeness, its accuracy, its reproducibility. That's a topic certainly for another time. But we can certainly also connect the historical dot from way back to 1918 when those brave surgeons were talking about transparency all the way to today, 2016. Next slide. This is just a deeper dive into what the Physician Compare website looks like and giving you, again, some of the ambulatory process measures for our very own practice, Jefferson University physicians, and I've been a proud general practitioner in that group for the last 26 years. And you can see our scores: getting a flu shot, screening for depression, screening for tobacco use, looking at body mass index, all the things that general practitioners, family doctors, and internists largely do in our country and in most of the world. So you can find out how are we doing right here in our practice plan with regard to these clinical quality measures of care. Next slide. Looking a little bit into the future as we come to the end of our time together, our country still delivers care that is largely fragmented. It's really, really important for us to appreciate that. Sure, we could put a new measurement burden on doctors to try to coordinate care, but there is a deep cost to care fragmentation. And that's what this is trying to illustrate, that if you're in a traditional practice setting, you have extra costs involved because we just send patients from practitioner to practitioner without any real care linkage. If we get paid a lump sum, I would bet that these graphs will change significantly. In other words, in a bundled payment environment, we will pay much more attention to decreasing care fragmentation and increasing care coordination. Next slide. Well, once again, you can't know where you're going till you see where we have been. These are early results from the Medicare Shared Savings Program. I noted these accountable care organizations earlier. I would say, colleagues, it's a mixed bag so far. We only have 2 or 3 years worth of good data. It's pretty clear that some of our accountable care organizations did reduce spending. Some demonstrated improvements in care coordination, but nearly half, 46% of those reporting in this wonderful detailed slide from the Commonwealth Fund, nearly half did not achieve any significant savings. So I would just say we're early on in this, and we have a lot more work to do. Next slide. So, speaking of more work to do, let me tell you about something very exciting, and a law that was passed just not even a year ago. June will be 1 year, where something called the sustainable growth rate, a very complex topic, but something called the sustainable growth rate for Medicare was obviated, and in its place was put the so-called merit-based incentive payment program, sometimes called MIPS, M-I-P-S. And I want you to see this as one of our concluding slides as to where we're going to go in the future for ambulatory payment. So let's focus on the pie. So the light blue, about a quarter of the performance will be weighted on how effectively we use the office computer. The red, 30%, how good are we now in not only categorizing those PQRS measures, but actually implementing improvement. How effective are we in utilizing resources? And the purple, how good are we, if you would, in the actual measures of our care coordination and patient satisfaction. So this gives you a glimpse into where we're going to be going, certainly in the next 3 years. Our practice plan here at Thomas Jefferson University is deeply involved in making this transition, and I'm very excited, along with members of our faculty, to be participating in this transition towards merit-based incentive payment. Next slide. So to conclude, some of our most important thinkers in this arena are colleagues like Drs. Peter Pronovost, Robert Wachter, and others, have begun to question, as have we and our faculty, have we gone too far? In other words, in the transition in the next few years, 50 cents of every dollar connected to an outcome measure, putting so much burden on doctors to do the measures, have we gone too far? Are we going to suffer what Dr. Wachter calls measurement fatigue? Other leaders in our field, like Donald Berwick, have called this the measurement festival, that we're celebrating measures without having a good sense of, do they really lead to improvement? And just this month, in our journal, Health Affairs, with our colleagues Larry Castellino and others at Cornell in New York, they categorized that doctors are spending somewhere more than $15 billion, with a B, $15 billion a year just in complying with reporting quality measures. You heard me right, that's correct. In the April issue of Health Affairs, Larry Casalino, $15 billion the cost of physician compliance with reporting quality measures, both in the office and in the hospital. So I think this is an important challenge for us for the future. Final slide, please. So let's review where we've been in the last 40 minutes or so together. We've tried to accomplish three things. One, historical overview of how did we get in the jam we're in. And certainly in the United States, this is an important story. It's really our top domestic issue, probably, along with the economy. 19% of the GDP getting us to number 17 in the world. We certainly could do a better job. In part two, I introduced the basic tenets of the Affordable Care Act, with a special emphasis in the last 2 years of the movement toward linking ambulatory outcome measures, pay for performance. And if you're going to measure performance, you clearly are going to need a new set of measures. And then in the third and final part of our time together, we chatted a little bit about the implementation of yet a new set of measures that are only 1 year old, called MIPS, and how that will change the very nature of out-of-the-hospital practice. Well, let me conclude with 2 minutes of shameless advertising. I'm so proud of our colleagues like Dr. Mary Cooper, the physician director of our global online program at the master's level in quality and safety, and her predecessor, Dr. Jim Pellegano, and the many faculty who help us all around the country. If you are interested in any aspect of what you saw in this webinar, I hope you'll inquire both online and by telephone and join us in our Master of Science program in Quality and Safety, our Master of Science program in Quality and Safety Management, our graduate certificate, and we also have an international program focused on comparative healthcare systems. So in conclusion, thank you for joining me today. I really enjoyed sharing a part of my day with you, and we have a big challenge ahead, and I'm looking forward to global collaboration, because at the end of the day, our core goal, of course, in addition to doing no harm, is to do the best we can for every patient encounter. Thank you again, colleagues, for joining us.
Thank you so much, Dr. Nash, for that fantastic webinar. So interesting and frightening at the same time to think of some of the challenges that are that face such a big country as the US. We have some questions here for you. The first one that I have, what has been the impact on the US of the reimbursement models on safety and quality?
Boy, that's a very important question. It's certainly mixed. There's research evidence that in the inpatient setting, we have made improvement in reducing, for example, hospital-acquired conditions like CAUTI and CLABSI. There's research evidence from the Agency for Healthcare Research and Quality at the national level that we have made great strides. On the other hand, every week, 20 wrong site surgeries are reported to the Joint Commission in Chicago across our great country. 16 years since the publication of To Err Is Human. So on the one hand, we have some improvement, and on the other hand, we have a long, long way to go.
Thank you very much for that, Dr. Nash. The next question I have here is there a reimbursement model that can enhance quality?
Yes, great question. I believe that the evidence will accrue to demonstrate that pay for performance improves outcome. And in fact, we have a saying in our college, no outcome, no income. In other words, like almost every other aspect of our economy, you're only going to get paid if you could demonstrate an improved outcome. So we're working towards this model, and the conundrum, of course, is while we push toward no outcome, no income, are we overburdening the individual doctor, and simultaneously, are we spending too much money to get there? I have faith that we will achieve this goal because we have to. We cannot continue to spend profligately like we do with little attention to guidelines, little attention to the evidentiary basis, a inappropriate focus on professional autonomy. The ambulatory safety story is one small part of the much broader context.
That's fantastic. Thank you so much. Another question here for you from Ashabir Kidan, who's in Ethiopia, and he thanks you very much for your fantastic presentation and asks, how can we organise or coordinate efforts to improve the delivery of patient-centred care in ambulatory settings, especially in resource-limited countries?
Well, that's a gigantic question for sure. I think I'm very excited about ISQua and the potential of Jefferson working together on global education in this area. I'm very committed to finding a way to create a global master's degree in quality and safety to bring this kind of thinking to areas that might be resource constrained. I think in the developing world, they actually have a fantastic opportunity because they're unencumbered by so much technology that we then overuse. So let's find out what's the best approach. Let's do appropriate research on that. Let's promulgate that, disseminate it, get it out to folks like our colleague in Ethiopia. I think promoting systems thinking is probably one of the greatest accomplishments we can strive for, and that will go a long way to improving safety and quality even in resource-constrained countries. Systems thinking, care coordination, these are the building blocks of a successful future system.
That's great. Thank you so much. David Wright in Australia, thanks you for a great presentation, Dr. Nash. And his question is, it would seem that the focus is on using measurement to manage costs. Is there a system in place to provide feedback loops back to clinicians for quality improvement purposes and/or contribution to policy development through aggregating data?
Wow, it's an excellent question, and I regret that I didn't have time to talk about closure of the feedback loop. Yes. So among the activities that our college does on our campus with our medical college colleagues is we have 5 or 6 folks devoted to giving physicians feedback about their performance. So closing the feedback loop, giving doctors good data in a timely way, adjusted for patient severity. We know from 20 years of research that closing that feedback loop is very important. However, just giving clinicians data about their own performance relative to a standard is not enough. We also have to teach them how to improve. So we know from the work of Brent James and many others over a long period of time that closing the feedback loop is step one, and then educating them on how to improve systems thinking, going on getting training from folks like us and others, giving them the tools to improve is very important. The analogy is, giving them fish versus teaching them how to fish. We don't want anybody to starve, so we'll give them fish, but much more importantly, we want to teach them how to improve. With regard to the policy activity, well, that's very important, and our college and our faculty are very deeply involved in the policy conversation for quality and safety. As I noted, our leader, Dr. Mary Cooper, is the Chief Medical Officer of a large state-based hospital association. She's implementing these measures across a large geographic area right now. So we have a very practical approach. We have a good, I think, pedagogic approach to these issues, and we're certainly involved at the policy.
That's great, Dr. Nash. Thank you so much. Next question we have from Ahmed Bilal, and Ahmed asks, how did the US overcome the obstacles in the transition of payment system, especially from the clinicians?
Oh boy, well, we're not done yet, so we're in the midst of that struggle right now. And I'm smirking, probably I shouldn't, but this is a big struggle. I didn't mean to imply that every clinician in our country understands, appreciates, and embraces these measures. I would say we're at the very early phase of the ambulatory struggle to get these measures into place. It's going to take probably another generation of practitioners before everybody understands and embraces these measures. That's a fantastic question.
That's great. Thank you so much. Another question in from Claudine Shepherd, and Claudine is in Trinidad and Tobago, and she says, great presentation, thank you. She says, I'm from Trinidad and Tobago, and in our healthcare system, we have just started measuring clinical outcomes. The challenge is one where our healthcare system does not have a system for feedback and also rewarding healthcare personnel. What suggestions could you give?
Boy, you know, that's very hard. Without, I could certainly say in our country, without closure of the feedback loop and without a strong economic incentive, we were not going to make too much progress. I think in the absence of an economic incentive, you have to appeal to physicians, you know, moral standing, what made them go into medicine in the first place, and giving clinicians, both doctors, nurses, pharmacists, the team, giving clinicians good information about how they could improve many times achieves a good deal of improvement in and of itself. In other words, I believe that doctors and nurses in Trinidad, if they were given good data about how they're performing relative to a peer group, relative to some normative measure, that alone would be powerful stimulus, generally speaking, for doctors and nurses and pharmacists to do a better job. Collecting the data is expensive, but even, you know, Don Berwick 20 years ago talked about sitting in the office and asking basic questions. Are we happy in what we're doing here? Are we satisfied with our level of care? Are we meeting the needs of our patients, and have we asked them what those needs are? I mean, stimulating that kind of conversation that many clinicians have never participated in, I think that's certainly an early step to take. Doesn't require any fancy technology.
That's great. Thank you so much. Another question here. Can hospitals, as the principal provider of acute care, survive as pressure from an aging population with comorbidities increases?
Well, that's a huge question in our country. So every day, thousands of folks become Medicare eligible. I represent the zenith year, so I was born in 1955. So in a decade, in 5 years, when I become 65, that cohort, born in 1955, that cohort, the thinking is we could potentially bankrupt Medicare because we're going to be the world's biggest overutilizers of services for sure, and will be a very demanding group. So it's a great question. The research evidence is mixed. Whether the Medicare Trust Fund will stay solvent when my peer group becomes Medicare eligible, this is an important policy issue. I think if we didn't implement aspects of the Affordable Care Act right now, we would be in much worse shape 5 years hence. So I'm hopeful that we'll be able to weather that storm in 5 years from now.
Great, thank you. Another question here. Babatunde Funkle thanks you for an excellent presentation and asks, is it possible to achieve the high quality care without the expensive high-tech equipment like they have in the US?
Sure, of course it is. A good part of the world has already demonstrated that. I mean, not for every diagnosis, but with regard to prevention and wellness, absolutely, absolutely. So-called upstream medicine, looking at the fundamental causes, very, very important. Very important. So there's lots of work to do absent the high technology.
That's lovely, thank you. Another question here we have, as the leader of a Centre of Excellence in Healthcare, what keeps you up at night when you think about the future challenges?
Great question, yeah. Well, at the end, I think right now I am focused on, do we have too many measures? Are we burdening clinicians, and they may revolt? They may just say, are we sacrificing the good on the altar of the perfect? And I do worry about that. And my clinical colleagues who are in practice full-time feel very put upon by the preponderance of measures. So I am very concerned about this currently.
Okay, that is perfect. Thank you so much. We have one more question here, and it's in from Leila, and Leila is in Lithuania, and she's asking about what about the patient's role as well in the outcome improvement?
Really important, and we didn't have time to talk about that. We talk about the concept of patient engagement, and that you can't really promote wellness and prevention without patient engagement. That would be a great webinar topic for next time. But patient engagement in this process is vital, and we're only now beginning to understand with behavioral economics and various other incentives how to really get patients engaged in their own care, recognizing too that the social determinants, poverty, are a critical component of this patient engagement. We have a lot of work to do on that side too. Excellent thought. Maybe the next webinar we could look at patient engagement.
Perfect, that's fantastic. Dr. Nash, thank you so much for your fantastic presentation, and also for taking the time to answer a whole lot of questions that were fielded at you there, which is fantastic. Thank you to the audience for your participation and your comments. That has been brilliant, and we really do appreciate that. Just to let everybody know, this webinar will be live on the ISQua website within 24 hours, and for participants in the ISQua Fellowship Programme, it will be up in Felix within 24 hours also, and you will also gain your credit points for attending today's lecture. So once again, Dr. Nash, thank you so much. I know it's quite early in the morning for you over there, so I hope you enjoy the rest of your day, and thank you to all the participants also. Have a good day, and thank you again.
Thank you again.